Hello and welcome to AvaSure's webinar, TeleSitting, What's New and Where It's Headed. Very exciting. We had over 500 people register, so lines are muted, but we would like it to be interactive, so feel free to type questions in the Q&A window. And we'll have a poll, and we're going to unmute a few authors of studies towards the end, so it will be interactive despite the fact that it's virtual. So this is AvaSure's TeleSitting What's New and Where It's Headed webinar. I'm Lizbeth Otruba, the Chief Clinical Innovation Officer at AvaSure, and I'm here with my colleague, friend, and mentor, Dr. Pat Quigley, and we're really excited to talk about the latest in telesitting and in the evidence. So just kind of go over what's next, the format that we're hoping to cover today. There have been so many published studies on telesitting that it's getting hard to keep up. So we have chosen some of the best and most recent to discuss today and kind of hope to whet your appetite with that or save you the time of having to do an exhaustive lit review. But the purpose of today is twofold. One is to go over what's new, what's really important that has been published recently in the national program of study that we're conducting. But the second is to really inspire more research. So every good study that you read ends with, well, more research is needed about this or more research is needed about that. If I read a study that ended with, we're done researching this topic, I wouldn't trust the study. There's always more to learn. And so we're hoping to pique some ideas and inspire people to plan their own research as well. And so we'll take the front half to discuss some studies, but we're going to leave plenty of time for Q&A, and we have some friends and colleagues that have agreed to let us unmute their mics and they can talk about the research that they've done and lessons that they've learned towards the end. So I want to start with an audience poll. So the first one is, where would you like to see more research done? What setting or settings? And so go ahead and click your response. I think you can click you can choose more than one option. And I will say that there's a limitation with GoToWebinar that we could only give 5 drop-down options. So that's why we've kind of combined some of them, maybe a little awkwardly, but this will give us a ballpark. And I see, looks like med-surg and acute care is out front, and the children's hospitals is about 14%. Okay, I'm going to give it a few more minutes. It seems like kind of, okay. So thank you, Laura, who is running the poll for us. So hopefully, Pat, can you see the
Yes, I can see the results. We had 54% that wanted ED ICU, 66% more research on med-surg and acute care. That was the largest. Children's hospitals was 14%, rehab LTAC was 20%, and skilled nursing facility was 25%.
Okay, great.
But indeed, the highest is med-surg and acute care.
Okay. And then the next poll, just the second one and the last one that we'll do is about what use cases or what types of patients. And again, we are limited to 5 options. So I actually didn't put fall prevention sitter reduction here because there's so much there. I just kind of wanted to pick some topics where I think there's not as much out there and available right now. So that poll is running. And so far, it looks like suicide risk patients are the most common research that people are looking for. Last poll, 75% of you all at least put in one answer. So see if we can get up to more than 75% answering this one. See 7. Okay. So we've got, 70, okay. Okay, again, thank you for your responses. 71% of you voted on this one. And pediatrics was 10% and 45% for staff engagement. So I agree that's important to study more about how do nurses and bedside caregivers, how much are they not only satisfied with, but engaged with this new technology for patient safety, patient and family experience. We're going to talk about that, as well as suicide risk patients and isolation patients. Those are all topics that we'll cover a little bit about today. So wonderful. All right. So this first study that I want to talk about comes from the Annals of Internal Medicine, and it sitters as a patient safety strategy to reduce hospital falls. And the authors there, you can see there were some physicians and scientists working on this together. And I chose this one because it's recent, and also because it's a systematic review of multiple studies. So that makes it a level 1 level of evidence. And it was commissioned by the Veterans Affairs Evidence-Based Synthesis Program Center. So I had noticed also that there are a lot of attendees or registrants from the VA health system and the Department of Defense. So it's interesting to know who are the authors and who's commissioned it, and what are they looking for when you're reviewing a study. And there's a lot here, and the references is listed, so you can read the whole thing yourself. But what I found most interesting and compelling was this table 3, where after they ruled in all the studies that they thought would be worthy of analyzing, they looked at the level of certainty of the evidence. And you will see that adding using sitters for preventing falls has a very low level certainty of evidence. And that the other interventions that involve not using sitters were low or very low, but the one with the most evidence is using video monitoring to reduce sitter costs without increasing falls. So at least having a null influence on the quality. And so this is a really great study. And I think for whether you are kind of new on your journey in analyzing whether telesitting is evidence-based or not, this is a great study. It is also good for those who might already be on the journey and have been using it, and they're trying to get more buy-in from the bedside caregivers. And bedside nurses, who are often the ones responsible for patient selection, may not have the time to read all these 20 articles that were reviewed here. So this would be a great thing to share with bedside staff, so they feel confident and realize that this is there's good solid evidence behind this as an intervention for patient safety.
Elizabeth, if I could just please add, I just share with all of our colleagues too. It's so great to be with you. So I have so many here. Is that this study actually was commissioned by the office, central office. This was a policy question from central office, and it was conducted by the Evidence-Based Center. But when you have a chance to read this article, what you'll see is there's a timeline of the literature that they reviewed for the systematic literature review, and this timeline did include one of the studies that you will hear from us that was published in Clinics in Geriatric Medicine that was not included in their systematic literature review. So we actually sent our research to them, to this whole team, to let them know about our findings that would have further supported the use of video monitoring. So thanks so much, Lisbeth.
Good point. And this is focused on falls. And the article that we're going to talk about later, the study that we're going to talk about later, Dr. Quigley is in Clinics of Geriatric Medicine specifically on fall reduction for and based on age. So it's very relevant. So that kind of adds to the weight of the certainty of evidence. This next study, I'm going to make sure my mouse is on the right screen when I'm forwarding, is a very interesting one, and it's a different use case. And so this is video monitoring to manage eating disorders on a general pediatric unit. Couple reasons why I thought this was important and worth including. One, it's again very recent. It was published in 2019 in the Journal of Hospital Medicine. And I like it also because of the interdisciplinary nature of the team. So the team of authors included nursing, pediatricians, pediatric psychiatrists, pediatric hospitalist, a registered dietitian. So that to me speaks of a great, well-rounded team that really looked at this issue closely. And then they had a good control versus the intervention group when they looked at their financial outcomes as well as their quality outcomes. So they compared using a nursing assistant to do one-to-one sitting with eating disorder patients, which was their usual practice prior to implementing telesitting, to centralized video monitoring. And they demonstrated that the nursing assistant was over $4,000 per admission versus closer to $1,000 for CVM, so a really good ROI. And that there were no differences in length of stay or weight gain, which were their quality metrics, as well as no occurrences of family refusal. And they actually didn't have any events where they had to discontinue the CVM for their previous practice of one-to-one sitters. So I have one criticism of this study is that there was an error in stating the cost of the technology. So they stated the cost of which they based their ROI calculations was for 6 devices, not 1 device, and it says 1 device. So we're corresponding with the corresponding author, but that would only make their ROI even stronger. So hopefully we'll get that clarified in the near future, but still a really great, well-designed, well-written study. And then this one is measuring patient and family experience. So this is continuous video monitoring implementation strategies for patient safe patient care and identified best practices. And Jackie Abbey and Christian O'Keefe are the authors from Oregon Health and Sciences, and I believe they're on the call today. And they said they would be willing to answer questions later. So a couple really interesting things about this study is they did show a cost saving of almost $200,000 in the first year, but if you read in detail, the first 3 quarters was about $36,000 savings per quarter, and then they improved even further, and they did leader standard work, and then they implemented a 2-hour trial of continuous virtual or video monitoring before going straight to sitters, and they saw an 80 to 90% success rate. So the nurse had requested a sitter, and they said before actually assigning a sitter, we're going to trial CVM, and they had a high success rate. So then in their 4th quarter, their cost savings jumped up to $86,000. So this is a great example of read this before you start your own program, so you don't have to, so you can stand on their shoulders and jump up to their next level of efficacy that they did after kind of regrouping and doing probably a PDCA. I also liked the wide inclusion criteria for multiple different reasons for adults in pediatric setting. And then the thing that is unique about the same study is that they did a family comfort survey, which I haven't seen done in other articles, where they surveyed families about how they felt about continuous video monitoring versus one-to-one sitters. So 80% felt that they had more privacy with the one-to-one sitters. 93% felt that the continuous video monitoring added security and more of a chance for respite. So they finally felt safe enough to go home and take a shower or sleep at home and come back in the morning. And then they found an area for potential improvement, which they talk about in the study, that only 55% of those that they surveyed had received the official education from their nurse about what continuous video monitoring is, that it doesn't record, that the person monitoring was an employee of Oregon Health and Sciences University. But that happens because people can kind of sneak into the room before the nurse gets a chance to walk in there and do the education. So something that maybe we'll ask Jackie and Christian about later, what they've done with that. One more presentation I'd like to mention is that in the American Psychiatric Nurses Association annual conference last October, I co-presented with Dr. Janet Sipkala-Gaffin on using our system for suicide risk patients. And I put a link, and we'll put a link in the chat, because you would be able to go to the APNA website and listen to the presentation, see the PowerPoint with it, and get continuing ed hours for it. And I think for non-members, it's $8, and I would love to give financial support to APNA. It's well worth it. And it's nice to get those continuing ed hours when you need them. But what we kind of talked about, and there's much more detail, of course, in that presentation, is the trend of increasing use of TeleSitting for suicide risk patients, low to moderate suicide risk patients. So ORNA is our online reporting of nursing analytics. It's the database that AvaSure hosts. And over the last, since first quarter of 2016, the x-axis here is quarter by quarter, how many hospitals are monitoring patients for suicide risk. And that trend continues to go up and up. So the y-axis is number of hospitals. The x-axis is the quarters for the last 4 years. And I think there's a few reasons for the bump up. In the fall of 2018, the Joint Commission published an FAQ stating that for high-risk suicidal patients, one-to-one sitters are needed, but for moderate to low risk, the use of e-sitters is up to the discretion of the individual hospital. So I think that's one of the reasons. And then in 2019, there was a study published out of Brigham and Women's Hospital, which I'll talk about, which I think also kind of continued that trend of using this technology for these vulnerable patients. So I talked in that presentation about the study out of Brigham and Women's Hospital that was published in General Psychiatry, and that was available online in 2019, but came out in the hard copy in 2020. So they did use AvaSure in the emergency department and the med-surg units for suicidal risk patients at one hospital. And Dr. Kroll is a Harvard psychiatrist who was the lead author, with a very interdisciplinary team that included nurses as well. And they had no attempts and no patient harm and no actual suicides. And then Beacon Health did a similar presentation in 2017 webinar, where they talked about having started implementing this in 2016 across 2 hospitals. They had about 500 patients that they monitored. They also did not have any adverse events or patient harm that occurred. And then we're able to aggregate across all the hospitals that are participating in the online reporting of nursing analytics, and looked at 24,000 patients that have been monitored for suicide risk, listing suicide risk as a reason for monitoring. And there were 16 descriptions of self-harm attempts, and no actual harm occurred to patients across 199 hospitals. So that's kind of replicating the same outcomes. And of course, there's room for more research. And so maybe this is the area that you might be interested in studying. And I saw on the poll that people want to have more studies on this topic. So I'm going to pass it over to Pat now to talk about our national multi-site studies.
Oh, thanks so much, Lisbeth. And I really hope that, what you've learned already, colleagues, from what Lisbeth has shared with you is just already so inspiring for you in terms of your interest in maybe conducting quality improvement program evaluation, but also research. But what we wanted to do with you for this part of this presentation is to really paint the picture for you of this progressive program of research that is so impressive, that is coming out of national studies, not single site studies, but national research being conducted with the ORNA database from the AvaSure company. Lisbeth, myself, and Jill Kaminsky, who is our data analyst, who is the clinical director of data and our co-researcher. She's really, I'm sure she's on the call with us. She just likes us to be able to present. But, as we present, we're going to share with you 3 original large-scale research studies that are all descriptive correlational studies. All the events, ladies and gentlemen, I hope you hear how impressive this is, are all witnessed events. There's no missed events. There's no going back to incident reports to figure it out or post-fall unwitnessed events. These are all witnessed events. And I want you to know that Lisbeth and I were invited just 2 weeks ago to present this progressive program of national research on patient-engaged video surveillance to the National Quality Forum, to the Leadership Symposium, which was very high level in terms of the members of the National Quality Forum Leadership Symposium. So the 3 studies that we're going to present to you is on prevented adverse events. I'll present to you on falls. And then Lisbeth is going to present to you the study, one of 2 studies that we have actually published, national studies on preventing, look at trending, tracking trending, and analyzing assaults on the nursing workforce. And then I'll come back and share with you, very exciting, and the very first national study to actually see what is going on in the adverse events with the COVID population during the surge. So as we share this with you, this is all groundbreaking research. So let's go ahead and get started. On the next slide, please. I am going to present to you the first study, the national study that we published in 2019 in Clinics in Geriatric Medicine, patient-engaged video surveillance for preventing adverse events. And we were invited to present and to publish in Clinics in Geriatric Medicine from my VA colleagues. You will recognize the editor of this was Steve Caslow, who's a renowned geriatrician out of the Greater Los Angeles VA. He chairs the Geriatric Research Education Center there. And he wanted something on falls. And we said, well, how about if we conduct, prepare a manuscript on patient-engaged video surveillance, which no one had ever done at all on a national level. So we submitted a proposal and Steve said yes. So we were so excited to share this with you at this study. And we hope that now that this is 2019, that all of you will read this article. Every one of these articles, we want you to read this. But as I share with you, because I know that there's some of you on this call that are new to this information, really seeking information. There are many of you who are using this the program already. And then my VA colleagues, we've learned that you really have more interest too in trying to prevent falls. But as I share, we all are very sensitive that progress has been, quite frankly, very slow on trying to reduce adverse events with a lot of the traditional methods, especially with fall prevention. And we are very aware that the Center for Medicare and Medicaid Services, CMS, has been trying very hard to send out funding to organizations to be able to reduce harm in hospitals over years, starting in 2010. So when you look back in 2017 to 2019, CMS put a lot of funding out to hospitals. They set a goal to be able to reduce harm by 20% in a 2-year period of time. Well, in 2018, when they presented their benchmark data of where organizations were with reducing harm, especially in falls, they had still only made progress in reducing falls, if you will, and other adverse events, like by 8%. So as I share with you what you're going to see in relationship to falls outcomes, you will be amazed at how safe this program is in being able to reduce harm across multiple adverse events in a year's period of time, not over years across multiple hospitals. So in all the available knowledge that we have in falls, there are still many organizations, and for decades, nurses have been relying on traditional mechanisms and services, traditional surveillance to be able to keep people safe from falls. And in trying to keep people safe from falls, they're still relying on hourly rounding, patient-activated call lights, and it takes so long for call lights. Even the research that's been done is 3 minutes to 13 minutes. A lot can happen in that period of time. Movement-initiated alarms, bed alarms. No one still measured timeliness of rescue to a bed alarm. And what about sitters? You just heard Lisbeth tell you about the article that was published by Greeley just last year in 2020, commissioned by central office in the VA to look at, is there evidence to support sitters? And there's not. So even as I share with you these traditional methods, I bet on this call, there are still people who are relying on these methods that the evidence isn't there to support it. It's not working. And this was physicians in the Greeley article who came out with from the evidence review that sitters isn't working, bed alarms isn't working, and that video surveillance may be the most effective. But remember, they did not review this published article. So in this article, what you will see, we had 71 hospitals. This again is a national study, 71 hospitals that we had data from that were enrolled in patient-engaged video surveillance. There were 15,021 patients that were enrolled. So what we have learned in this study, and when we conducted this because at a national level, is because single studies had been published before that. The first one in 2013 was a study that looked at a lean initiative for rolling out patient-engaged video surveillance, a 2015 single study to be able to look at the cost effectiveness of putting sitters back at the bedside. And then, of course, Lisbeth Bortruba, who had the first prospective study that she conducted that was a trial. So this is, again, the first national study. So it is, because it's a correlational descriptive study, that may have been the reason that it wasn't included by the physician evidence-based group, because they have criteria for selection of articles. But when you have such large-scale analysis of data and the outcomes are so confirming, it is enough to be able to change practice. So we were interested in trying to analyze, and we did, the analysis of falls and other adverse events by age distribution. And why did we select these age groups? Well, 18 to 64, that's the adult population. Before you get to 65, where we know in 65 and older, at least in the community, 1 out of 3 will fall at least once a year. There's a wonderful study that was published back in 2014 by Levant and others that looked at age distribution of the aging population in hospitals. And this was their age groups, except that they had 65 to 74, 74 to 85. We collapsed that age group. I want you to know we had methodology behind selecting our age groups. Is that when you collapse them, this is a population who are fallers, but they're also already have a fall-related history of injury, they're osteoporotic or anticoagulated. And then we've got our 85-year-olds. So we wanted to look at the age distribution. Then we wanted to trend verbal engagement and alarm rates and alarm response, the adverse events, falls, room elopement, line and tube drains, dislodgement. And then were there any differences from age, monitor engagement, and response times? And of course, there's cost. So we're not going to have time today to go over all of the answers to these research questions. So I know you're going to be so inspired to, to read this article. So as you continue to look at this slide, I want you to see that there are rates here. And you know that this data was reported from the analysis. But I hope that there are some of you who have pencil and paper to be able to write, because I want to give you some numbers here. When you heard on the very first slide of this one study, there were 15,000 patients that were in this study. Well, in the age group of 18 to 64, there were 5,173 patients. And in this age group, they had 34 falls. 34 falls. This is the age group that includes your if you will, middle-aged adults, your 50-year-olds who overestimate their abilities and have autonomy, and they're going to get up without you. So 5,173 patients, we had 34 falls. In the age group 65 to 84, in this age group, we had 6,393 patients in this entire age group across 71 hospitals. And how many falls were there? Are you ready? 22. 2. That's 2, 2. Oh my God. Can you say that in your own organization? Let me take you to the 85 and older. So why is this group important? Because, ladies and gentlemen, every one of you should know that this is the age group where if they fall, they die. Falls is their #1 cause of unintentional injury death. So in this age group, we had 3,455 patients, 3,455 across 71 hospitals. And do you know how many falls they had? 3. 3. There were 2 that were unassisted, 1 that was assisted. I mean, this is amazing. So as I share this with you before, you have the fall rates here. Lisbeth has highlighted a fall rate of 0.38 per 1,000 patient days of surveillance. Do you know how close this is to 0? I mean, this is getting to 0, where falls hardly exist. Even in the other age groups, the fall rates are so low. I'm sure that they're lower than the age group, the fall rates that you have in your organizations. But as I shared with you numbers, and I hope some of you wrote them down, and again, I'm inspiring you to read this article. For the total number of patients, 15,021, there were only 59 falls that happened in the entire year from January 2017 to May 2018. No one has made this rapid patient safety protection of reducing falls like has happened with all the organizations who were involved in using patient-engaged video surveillance at all, to get to almost a desert, which Brad Playford likes to say, the founder, CEO of AvaSure, that a desert where falls hardly exist. So 59 falls had occurred and no one fell twice. So I just want to make sure that you hear how impressive this is. Overall, a fall rate of 1.5 per 1,000 patient days. So you can see the assisted and unassisted, and then as well, you also have the elopements and the line elopements. So you got those adverse events right, but we really wanted to emphasize the falls. And if you could go ahead and just advance again for me, Elizabeth. We just really be able to go ahead. That's it. Is that you really appreciate that no one fell twice. So when you look at the findings, it's okay.
Can I just chime in that those 15,000 were selected for monitoring because the nurses felt they were high risk. So that wasn't a random sampling of 15,000 patients. They were high risk patients.
Right. All of the patients that were enrolled were because of high risk. That's right. High risk for falls. So thank you so much. And then also, I just want to make sure, even though I said 59 patients who fell, I always make sure everyone hears the other side of the equation. And what's the other side of the equation? 14,962 patients did not fall that were considered to be high fall risk. So what did we find overall? Is that the oldest and the most vulnerable patients experienced the lowest fall rates, 0.38 per 1,000 patient days. Can any of you say that? Can any of you say that a patient didn't fall twice in your care, that you went a whole year with no one falling twice? Oh my goodness. Nurses responded to the oldest patients 3 seconds faster than they did to younger patients. And you know, that's why when you looked at them, you saw who was assisted and who was unassisted in terms of falls, only 3 falls, and most of them were that they were assisted. And then the patients who fell had 5 more verbal interventions per day and 0.83 more alarms per day than the non-falling group. And this was statistically significant. So the monitor techs, actually, they were trying to keep them safe. They were activating the alarm. They were doing all that they could to be able to get someone there to be able to help rescue them. And then the staff nurse response time who experienced unassisted falls was slower by just 19.2 seconds compared to 5.3. So just the difference between 3.4 seconds made a difference, and maybe who could have had an assisted fall. And that neared statistical significance. On the next slide, please. So the results are so very impressive. So when you look at the cost savings, which is what we were very interested in as well, is that to be able to provide 4,082 hours of monitoring, which is what was done. This is one-on-one surveillance. That would have taken 453 annualized FTEs. So, that's the cost savings when you go ahead and use a program where you have 1 to 12 patients to be able to keep these patients safe. And you saw the safety net. So we actually reduced and put people back to the workforce, because this only took 38 FTEs. So the cost savings is indeed contingent still on the hourly wages and one-to-one monitoring that you can see. So I hope that this has been impressive to you and that you will go back and read this article. So Elizabeth, I know you're excited to present the next study.
Yeah, thanks, Pat. And I haven't, thank you for summarizing that. I hadn't kind of thought about that article for a while, and now I'm proud again.
It's amazing.
So thank you.
Everybody should be taking this to your boards of trustees, your CEO suite. No one, across 71 hospitals, 59 falls, no one fell twice. Oh my gosh. Yeah.
So I'm going to talk a little bit about our workplace violence prevention articles that we've published. I'm going to focus on the one that was in the Journal of Nursing Care Quality. But recently, over the last probably 6 or 7 years, there's been an increased call to action. So AONL, which was then AONE in 2014, along with the Emergency Nurses Association, published guiding principles about mitigating workplace violence way back in 2014. And I think this was based on some studies that were some really good studies that came out right before then, showing that 54% of emergency room nurses had experienced physical or verbal abuse in the last week. And then there was another one that, when asked the last year and beyond, outside of the emergency room, where it's kind of the front lines, it was 74%. So we can no longer say it's part of our job and that it just happens, or that the amount that actually gets reported to employee HR or employee health is minimal compared to how much it's really happening. So they were both AONE and the American Nurses Association published a position statement on it, both calling for zero tolerance, more education, leadership support, start a committee, just trying to say we need to do something. And then OSHA published in 2016 guidelines for preventing workplace violence. And this is often cited where the statistic is first shared that healthcare workers are 4 times more likely to be injured than non-healthcare workers. And a real call to action there too, to start gathering more data and increasing reporting. And then when the Joint Commission comes in, people really start paying attention. There was a Sentinel event alert in 2018, also encouraging the use of any data source to document workplace violence events, and also to include verbal abuse, not just physical abuse, and also to include times when harm is attempted, even though no harm occurs, and not to ignore those, to learn from those near miss situations as well. And then the National Quality Forum published something very recently, and although their lit review was in the time frame of our article that we published, it wasn't included. So then Dr. Quigley and I 2 weeks ago got a chance to present at NQF and talk about that, and talk about how telesitting or patient-engaged video surveillance can have an impact. So this study, the sample was 73 hospitals across 21 months and 15,000 patients monitored. And we were looking at the impact of patient-engaged video surveillance on nursing workforce safety. So we did a qualitative analysis of the events that occurred and that were witnessed and documented by that third witness in the room, which is the TeleSitter monitor. And there were over 300 events, and the verbal incidents, profane language, yelling, threats, name calling, but verbal incidents are rarely reported, but death threats are definitely going to have an impact on the emotional well-being of bedside caregivers. And then there were 193 actual physical incidents that were also monitored. And we described them in more detail in the article. But the takeaway was that nurses, most of the patients that had a violent incident were not being monitored for violence prevention. They were being monitored for fall prevention. And then there were patients that were selected because the nurses thought that they might have violent tendencies, and about 5,000, but only a small group actually were physically violent. So here's one case which I said before, there's room for more research, and the more research is how do you identify which patients might have the tendency to become violent. The abusive patients required more monitor staff intervention than non-abusive patients, and the bedside staff responded faster to these patients. And I really believe that once you're on a nursing unit and you have a cohesive care team, people are kind of aware of which patients have these tendencies, and they run a little faster to help their coworkers. And the most important thing, though, was for every abusive event that was witnessed, monitoring staff documented that they were able to avoid 25 abusive events. And so that events avoided was what the Joint Commission is looking for, and that really helps hospitals analyze and plan better. And then I'll pass it back to you, Pat, to talk about our COVID article, which should be coming out. Like, I haven't checked today. It might be out today.
That's right. And you heard about the article in Nursing Care Quality, but we also published the Workplace Violence in the American Nurse Today. And that's why I say you're hearing one. So, we are advocating, Elizabeth and I are actually advocating for the patient engaged video surveillance, this whole program, to be one of the workplace safety initiatives in the American Nurses Association. Their two major initiatives have been needle stick injuries and safe patient handling and mobility. And this is the work that we could do to be able to protect the workforce. So, hopefully, people will see, because if you read the article that was the work group from NQF that was published and their recommendations, many of it is still the same things that people have been doing, relying on nurses to come forward and report that something happened, which they're not going to do, or surveying them. So it is very exciting. But as we share this article with you colleagues, oh my gosh, this is cutting news. You are on the brink of cutting news. So, this is MedSurg, the Medical Surgical Journal. And if you were to go onto the Medical Nursing Journal website, you would see that our article right here is at the top of the list of upcoming featured articles. So it was scheduled to be published, as you can see here, March to April or March to April for 2021, but it has not, we're still waiting for it. But you're getting to hear about it, as did the National Quality Forum Leadership Symposium that we presented to last week. They were very interested in this. So all of you have been impacted by COVID. We know that you have been impacted by COVID this year. And on March 11, 2020, as you know, the World Health Organization declared COVID-19 the outbreak as a pandemic, a global pandemic. And that was the fastest transformation ever that has ever been seen in the healthcare industry, and was witnessed worldwide, with the transition of population healthcare to everything that we had to do for the emergent care situation. So for all of you who are on the call, everyone at the bedside, our RNs, everyone on the front line, especially our RNs, was really trying to command every single resource they could have to be able to manage and protect these patients. The patients that had COVID or were present under investigation, being evaluated for COVID. So what we started seeing, and remember, this was March 11th that there was this surge, the pandemic that was declared, is that we knew that there was going to be a surge in the hospitalization of the infected and the suspected patients, and this was going to challenge the entire healthcare industry to go full-scale isolation and operation, to move all of healthcare this way. So again, with Jill and the great work that she does with the clinical data analytics, they started to see that there was the first patient that was enrolled because of COVID in March with AvaSure. So even though we present to you 97 hospitals that in the surge months that were starting to admit COVID-19 patients into AvaSure, still the predominant reason why hospitals were admitting into AvaSure was still fall risk. So during this period of time, the 2-month period of time, there were 1,625 patients out of 32,130 patients that were enrolled because of COVID. So that actually totaled 98,918 hours of observation throughout all this time for these patients. So you can see on the map of what was occurring as across the entire state, across this great country of hospitals where the nurses were starting to engage the patient-engaged video surveillance. So as you can see here, if we go to the next slide, with 1,625 patients, that there were only 42 patients that had adverse events that were experienced during this period of time. So of the patients that were being monitored, 52% of them were male and 48% were female. So, you know, there was a shared distribution in terms of gender. And of those patients, there were only 9 falls that actually occurred. So the patient population that actually was enrolled too, 93% of them were over the age of 63. And we still had patients who were over the age of 80, 89. Those were those that were having observation for the COVID population. So you can see, even with the only 9 falls out of that 1,600 patients, this is just truly amazing. There were 2 intentional self-harms and 2 abuses that actually occurred, or they actually tried to physically, 2 self-harm and 2 physical abuses with the nursing staff. On the next slide. So as you look at the outcomes here and you compare them to 2019, the first article that you heard, and then this article, what you can see is that, yes, there were more falls with the population that was monitored, but it took a little bit more time, response time, for the nurses to get into there because of the PPEs. So the response time to the alarms was, in the original study, was 15.18, the 2019 article, and then it was 34.5 for this one. So it did take a little bit more time. But look at the verbal interactions. There was still just a little bit more verbal interactions, 15.8 compared to 17. But the point is that even within this, with the verbal interactions, many of the patients that had no adverse event, there were indeed more verbal interactions, so that the monitor techs were helping to provide comfort. They were because people were afraid, they were isolated. So there was a lot of verbal interactions still per day for this COVID population in the environment. But we want you to see that the most significant adverse event was now the dislodgement. So this was the dislodgement of lines. You know, people couldn't get in there fast enough to be able to help, you know, respond to the alarms and be able to maintain that safe environment and keep those lines in place. So that was what we found in terms of the adverse events and comparing them. So this slide actually helps you to see that during the surge months of March to April, you can see where we had that surge. So at the time in April, where we had a spike, that was where there was the largest number of patients that were enrolled, 92 patients that were enrolled across the country because of COVID, or COVID patients under investigation for COVID. And then it came down. And so, you know, our study was only March to April, but AvaSure has been able to trend the enrollment because of COVID throughout the entire 2-year period of time, or almost a year's period of time, from March 2020 to February 21. So the number of patient admissions now, as you saw, was over 7,000 across the country. So across all of the organizations, the 97 that we had, nurses were re-engineering the use of COVID. They were bringing in physicians, they had respiratory therapists, they had chaplains, they were using even families. And we heard so many stories and that were in the annotated notes within the ORNA database of how the interdisciplinary team really got involved in re-engineering and repurposing the patient-engaged video surveillance for the isolation population. So I think that you can agree that it is truly amazing. Even in those surge months of March to April, there were only 9 falls that occurred over 1,600 patients that knew that they were alone. And it helps us to know that we really need that nurses were helping patients to really understand we might not be able to get here quite as quickly as we can, but we're going to do everything that we can to help you. So as we share with you these 3 national articles, and you're on the cutting edge of this progressive research portfolio that AvaSure has, that is just, it's really impressive of the patient safety net that you are seeing across the board, across these studies, not just for patients, but our nursing workforce. But this is a shift in nursing belief that this is nurses culture, that it can shift, and that nurses trust and use this new technology to improve patient safety and outcomes. So if there's some of you in the audience that are very interested in seeing, do you have an organization that's willing to adopt this? You should know how many of you, what's your culture? Do you have early adopters? Look at the innovation diffusion model, because this is what happened. In COVID-19, people re-engineered this and they fast-tracked it, and AvaSure responded. Many of you are aware of that. And looked at plan change theory, because you want to make sure that it's fully utilized, that you're maximizing capacity to keep people safe and use this technology. Real-time surveillance does indeed decrease noise, the stimulation of the alarms, and increases rest and sleep. So there were no bed alarms. You can eliminate all of that. And the real-time surveillance provides much better focus for nursing practice. We call this nursing practice evidence. That actually is, I'm gonna forget her name, that came up with that on our advisory board.
Dr. Melanie Dreyer, and I believe she's on the call.
That was her term about what you're seeing in terms of the evidence, that this is nurses who use this, and this is the evidence of their practice in integrating technology at the point of care. So this is nursing practice at its best. So it's all good, but okay. And then more falls are prevented within and beyond the bedroom. So we know that this can be done. You know, when you start getting at the hallways and the rooms, and patient-engaged video surveillance indeed increases safety for patients and caregivers, and the true safety net is, and that does indeed exist. No false alarms. So we know that patient engagement is essential. So I know that that wasn't at the top of the list for more research, but we hope that you'll do more research and follow up with our colleagues from Oregon. So I know I'll just pass it back to you, Lisbeth.
Yeah, good. So yeah, I think I was gonna ask to unmute Jackie, Abby, and Christian O'Keefe, who authored the Oregon study, and they did the family comfort studies, if you'll remember, and did that kind of PDCA. So their third quarter in, they just really increased their, improved their outcomes. So I'd like to ask Christian and Jackie, I know they talked to Pat and I about a week ago, said that they were, quote, itching to do another study. So now that you've heard the poll responses and given it some thought, Christian and Jackie, what do you think you're going to study next?
Hi, Pat and Elizabeth. Can you hear me?
Yeah. Hi, Jackie.
Hello. Well, definitely inspired. Of course, I think that, you know, the things that people were mentioning were staff engagement, that they really want to hear a little bit more about that. I would say for implementation, it's all about getting your staff engaged and part of the process. And so I think one of the next things we might do is look at what Pat had mentioned is our readiness for spread, and, you know, is our program ready to grow, and do we have the right buy-in, and what does that look like from the staff nurse perspective? And I think, you know, you talk a lot about post-COVID and patient satisfaction and all these different things you're looking at and how we utilize our technology. And I think that more so than ever, our staff are engaged and bought in, just simply because they see all the uses of this technology, which of course this presentation showed. So I'm inspired. What about you, Christian? Oh, can't hear him.
I'm trying to unmute Christian and it's not working, so it might be Jackie, you're the voice.
That's okay. I was afraid mine wasn't going to work, but yeah.
No, yeah, that works great. And also on the line, I believe, is Dr. Hank Hrdlichka and Lisa Califas. Lisa is the chief nurse of Gaylord Specialty Healthcare and LTAC, a very reputable large LTAC in Connecticut. And I know that you are on your way, that your protocol has already passed IRB. And so we have a couple minutes left if you want to describe which aspect you're looking at.
Sure, Lisbeth, can you hear me?
Yes, hi Lisa.
Okay. First of all, I just want to thank you. This was wonderful, and we are all very excited to have AvaSure TeleSitting program at our hospital. We did just go live the end of January, and we're already seeing fantastic results. So we're excited to see what happens with our research project. But similar to what we were voting on in the beginning is I'm actually looking for more research in the LTAC community. So that's what triggered us to, decide to look at falls, amongst the telesitting patients in the LTAC community and those that are not. So we're going to be focusing also on our stroke population. We see a lot of patients that are recovering from stroke, unfortunately have falls. And we're in an institution where we're encouraging people to mobilize and move around, yet we're very nervous about them falling. So it's kind of a very difficult patient safety concern for us to manage here at Gaylord. So we think AvaSure is really going to be helping us with that.
And if I could respond, I'm so excited for the great work that you have going forward, because I'm a rehab nurse as well. And even when you think about the stroke population, who's going to follow the right brain CBA? They're impulsive, they got the safety denial syndrome and think they can. So that's a very important population when you start looking at populations to really implement this. I mean, every stroke patient that's a right brain CBA should be under surveillance. Because, and if they do fall, which is we always want to say that if someone does fall, it's a learning event. But it's witnessed, so you know what happened. It's not like we know for everyone who's on the call, so many of the falls that are outside of this program, they're unwitnessed. You don't know what happened. You have to spend all this time in the post-fall huddle because no one was there. But if it does happen, you know exactly what happened. And I should have said, and I apologize, I didn't, and that with the COVID population, 8 of those falls were unassisted, 1 was assisted. The nurses couldn't get there fast enough, was what we know. And the response rate was 35.4 seconds. That's still seconds, it's not minutes, which was a little bit longer than the 14.5 seconds that we're used to on a national level. But I'm very excited for the work that you're doing for LTAC, absolutely.
Great,
so
thank you.
Yeah, I'm getting the message that we were able to unmute Hank as well, and it was fun talking to you because you're not having the nursing background, but the research background. So, and you wrote a great protocol. So is there anything you want to add about how you're planning to look at it in your unique setting?
Hi there, can you hear me?
Hi,
Yeah.
yes, can hear you, yes.
Excellent. I guess we're trying to so with our protocol, what we're trying to do is learn from all the great literature, a lot of what you presented today, and just kind of mold that to our institution. So we're really looking, as Lisa said, really looking at reduction in falls, but then also we want to take into account all the various diagnoses and different populations that we do have. So with stroke being as Lisa said, with stroke population having the highest fall rate, we want to also try to look at all the diagnoses and take that into account. So we have all the different units, but look really at that diagnoses to see which are going to play a big role and what we can do.
Thank you so much for doing that. And I'll wrap it up now because we're coming at the top of the hour, but the longer I get into my nursing career, the more I really value the nursing code of ethics. And looking at the nursing code of ethics, the first 3 provisions are about your duty to your patient. The next 3 are your duty to yourself and your colleagues in your care environment. But the last 3 is kind of goes more global, and it's really your duty to healthcare in general and to the community to influence policy. And provision 7, I wrote it down, is specifically about advancing the profession through knowledge development, dissemination, and application to practice. And so this is not just a nice thing to do when you have extra time, but really it's our ethical duty to disseminate knowledge and to find new knowledge and advance our practice in patient health care. So thank you, all of you that are doing that even in a crazy year like this. And so thank you all for your time, and we will answer questions by email if we weren't able to get to them. Thanks so much.
And if we can help you, let us know.
Yes. Thanks, Pat.
Thank you. We're so excited for you all.